Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, it's going to be a little bit of a short one, but I just want to be complete here of all the main seronegative spondyloarthropathies that they might ask about on test day. And this is part of our mnemonic here to remember the key 4 ones I'd like to ask you about. And so remember, in the first pathology, we talked about psoriatic arthritis. Then in the last video, we talked about ankylosing spondylitis. Now we're going to talk about IBD Associated Spondyloarthritis. And again, we'll find in this video soon that this is really just a combination of a spondyloarthritis presentation with other classic inflammatory bowel disease, such as ulcerative colitis and Crohn's disease. And then in the final video, we'll talk about reactive arthritis to complete our series. Again, this is not an all-inclusive list, but time and time again, these are the ones that they like to test people on. These are the ones they like students to know on test day. And so I really want to keep it high yield in this chapter and make sure that you're super comfortable with these 4 pathologies, because I think you're going to get most of your questions right on test day if you are familiar with these. So when we think about IBD-associated spondyloarthritis, again, it's really just a spondyloarthritis. It's all the things we talked about in the overview video, all the things we've been talking about in this chapter, in combination with a patient who has an IBD or inflammatory bowel disease presentation. So we think about the pathophysiology here. Again, it's a seronegative spondyloarthritis. Seronegative meaning that it is negative for the IgM rheumatoid factor. It tends to have a bit of an unclear pathophysiology at this time. We don't really know what the mechanism is behind this, but we just know there is an association to the point that we actually kind of call it its own separate thing. And like I said previously, this is going to be associated with patients who have Crohn's disease or ulcerative colitis. Remember, these are types of inflammatory bowel disease, which is a group of conditions that lead to recurrent inflammation in the intestines or the GI tract for patients. Now, when we think about our presentation here, it should make sense to us that these patients classically have IBD symptoms, right? Diarrhea, possibly bloody if we're thinking about ulcerative colitis, abdominal pain, and weight loss. Anytime a patient presents with these conditions, this is one of the things that need to be high on our differential. Does this patient potentially have an inflammatory bowel disease? Are they potentially having inflammation in their GI system that's leading to these findings, this clinical presentation? Now, we can also see some asymmetric oligoarthritis, and we talked about this previously, right? Monoarthritis typically deals with one joint, oligoarthritis typically deals with a few joints, and polyarthritis typically deals with many joints. So these patients can present with something like ankle pain and knee pain. Oh, and also I've been having abdominal pain and weight loss. This is a combination, right? This is kind of a hybrid condition. We have our inflammatory bowel disease on one end, and then we have our spondyloarthritis on the other end. It's a combination of 2 pathologies that have a lot of overlapping characteristics. And so in addition to the GI symptoms, these can also have some other symptoms, including uveitis, enthesitis, which again is the inflammation at the point where the tendon connects to the bone. Classic one is the Achilles tendon insertional point. We talked about this as an insertional tendinopathy, and dactylitis, which is kind of where you get the swelling or sausage-like fingers of your digits. These patients are typically going to be diagnosed clinically, but we know that there's going to be an associated with the HLA-B27. They're also likely to have increased serum labs, including CRP and ESR. Why? Because again, this is an inflammatory condition. When we have inflammatory conditions, we often have inflammation or increased inflammatory markers in the body. Now, when we think about management for these patients, there's really 2 key things I want you to keep in mind. One is dealing with the acute symptoms. This can include things like oral anti-inflammatories or potentially glucocorticoids. It's really about getting that inflammation down, calming down the immune system. The body's reaction that's leading to inflammation can help with their acute symptoms. However, these patients often have an underlying condition, and that needs to be addressed. It needs to be treated, right? They have an inflammatory bowel disease, right? Typically Crohn's disease or ulcerative colitis. This needs to be treated with things like DMARDs, TNF-alpha inhibitors, or potentially mesalazine. So that's really it. That's really all I need you to know for test day. So again, this is kind of a bit of a hybrid condition. We have our inflammatory bowel disease with some additional findings, some spondyloarthritis type findings, some joint pain as well. And so really when it comes to test day and even in clinical practice, this is kind of a diagnosis of exclusion, right? A patient is going to come in with some abdominal pain, and if you can combine that with some arthritis joint type pains, maybe they have this hybrid condition. Now, it's really important and worth noting here that a classic way they can trick you is to give a patient who is presenting with an acute flare of inflammatory bowel disease. They can come in with abdominal pain, they can have elevated inflammatory markers, they can be febrile. There are all these things that can be going on with these patients, and then they mention, oh yeah, I have joint pain. Well, we have to be sure that we don't simply jump to the IBD-associated spondyloarthritis. We have to rule out septic arthritis as well, because if we don't, that would be a huge miss. If a patient comes in with joint pain that's very swollen and red and with all these inflammatory markers, and we don't work them up for septic arthritis, such as doing arthrocentesis and looking at the joint fluid, we might not treat them appropriately. So again, that's when I get back to this. This is a diagnosis of exclusion. You need to say this patient likely has an inflammatory bowel disease workup. They likely have a Crohn's disease or ulcerative colitis flare, in addition to some joint pain that is not the septic arthritis variation. So potentially question writers could ask you something along the lines of, a 33-year-old patient presents to the clinic with a chief complaint of bloody stools in addition to knee and ankle pain. The patient reports no recent traumas to the area and is unsure if activity worsens the joint pain. The bloody stools have been present for about 2 weeks, and the patient has also had a 10-pound weight loss during that time. The question could then go on to ask you, what is another associated finding with this patient's most likely condition? So again, in this question stem, a patient comes in with potentially inflammatory bowel disease in addition to some non-specific joint pain. Some other associated things that this patient could have include the things right here. Uveitis, enthesitis, or dactylitis could be present as well on physical exam findings. So just a quick recap of this video, overall fairly short, not super high yield, but I want you to be aware of this. This is IBD Associated Spondyloarthritis. It's a combination or a hybrid between inflammatory bowel disease, typically Crohn's disease or ulcerative colitis, and a spondyloarthritis. So all the things we've talked about previously. This is going to be seronegative, and it does not have the rheumatoid factor. Pathophys is unclear. Presentation is going to be a combination of GI symptoms along with musculoskeletal complaints, in addition to some other findings that may show up as well, such as uveitis. Diagnostics here, again, not super helpful. This is a clinical diagnosis. This is a diagnosis of exclusion. Management is really going to be based around symptom management for an acute flare or dealing with the underlying chronic condition, if that is the inflammatory bowel disease after all.